This program is brought to you by Emory University.
Good morning, everyone. Thanks again for joining us for Friday Morning Fellows Conference. Our speaker this morning, you all know him and probably love him, Dr. Arnav Kumar. Dr. Arnav Kumar. Arnav's a fourth-year fellow, getting ready to graduate here in a few months. He medical school in India, came to the United States, did his residency in Texas at UT Galveston, then did an imaging fellowship at Cleveland Clinic between residency and fellowship, came as part of our clinical investigator track, did research with Dr. Samity, and will be headed to Boston next year to pursue a career in interventional cardiology and structural heart disease. And he looks like he's going to talk today to us about advanced imaging and computational technologies. Arnav.
Thank you, Dr. Williams, for the kind introduction. Good morning to everyone who logged in today. Thanks for coming. So these are our specific disclosures. So the objectives of today's talk are, is ischemia the right metric to select patients for revascularization in stable CAD? The role of shear stress in plaque progression and plaque transformation, and we'll talk a little bit about emerging applications of computational imaging technologies to plan complex cardiac interventions. So the Courage trial and the Barry 2D trials, along with several other stable CAD trials, recruited patients with chest pain who had angiographic stenosis and a positive stress test. Yet both trials failed to demonstrate the benefits of revascularization in these patients over optical medical therapy. So a meta-analysis was done in 2012 with over 7,000 patients, which confirmed that in multiple stable CAD trials, revascularization did not lead to a significant improvement in heart cardiac outcomes. The story, however, that started to circulate was that stents do not work. And even the New York Times printed interviews of leading cardiologists on how there were perhaps ulterior motives behind coronary stent placement. So a few days back, Dr. Spencer King and I were exchanging some emails. In his recent editorial, he questioned whether ischemia is really the best metric to predict future ACS. He then drew my attention to a sub-study of the Courage trial, and he asked, what if anatomic disease was the metric to revascularize instead of ischemia? And I looked at the Courage trial sub-study, and in this study, a score based on anatomical parameters was made to define CAD burden. And this score far outweighed ischemia in terms of predicting future cardiac events. Recently, we participated in a Canadian registry-based study where over 9,000 patients with high-risk coronary anatomy were followed for more than 10 years. Now, these were patients with stable CAD who had left main or three-vessel disease. We found that in this group of patients with left main or three-vessel disease, revascularization was associated with lower risk of deaths and MI compared with patients treated conservatively. Yet we ended up spending millions of dollars on another trial, and this time most patients enrolled into the ischemia trial had demonstrated moderate to severe ischemia and also significant epicardial narrowing based on a cardiac CTA. And perhaps not surprisingly, the ischemia trial demonstrated that there were no significant differences between the invasive group compared to the medically managed group in terms of combined cardiac outcomes during the follow-up period. Now, what about intracoronary hemodynamics? Measurements such as FFR. Among patients with significant FFR, the primary endpoint of MACE was significantly lower in the PCI arm compared to medical therapy arm. However, these results were primarily driven by a significant reduction in the need for urgent revascularization. Actually, the rates of death and the rates of MI were quite similar in both arms. So hence there was another round of meta-analysis. And again, the stories started that revascularization does not work in stable CAD. In our recent editorial, we noted that perhaps these trials indicate that our current diagnostic strategies fail to identify patients at higher risk of future ACS and hence will benefit from cardiac interventions. Perhaps it is not the stents, but how we are selecting these patients for revascularization is the bigger problem. Now, some studies have looked at using intracoronary imaging modalities to identify vulnerable patients using markers of high-risk plaques. In the PROSPECT and the ATHEREMO trials, the positive predictive value to predict future ACS using IVUS-based markers such as plaque burden, minimal lumen area, and thin cap fibroatheroma were modest at best. Even when we used near infrared spectroscopy, which basically we use to identify plaques with large lipid cores, the positive predictive value to predict future MACE was only 12%. Part of the reason why we are unable to predict future ACS with a high degree of assurance is that there are different types of vulnerable plaques, which include plaque rupture, plaque erosion, and vulnerable plaque with calcified nodule. Now, we believe that local hemodynamic forces, such as shear stress, by causing local inflammation, may play a role in atherogenesis and ultimately vulnerable plaque transformation. As you know, some coronary plaques become quiescent and remain dormant and cause no symptoms, while others develop into one of the substrates of ACS. Yet other plaques become fibrotic and scarred and cause angina and demonstrate minimal risk of future ACS. In nature, we see that the inner curves of river often have slow flowing water, and these inner curves often show self-deposition, whereas in the outer blanks, often there is fast moving water and they show erosion. In the coronary tree, we often observe laminar flow causing physiologic shear stress in the non-diseased portion of the epicardial vessel. Some portion of the epicardial vessels, such as those near the inner curvatures and the bifurcation zones, demonstrate low and oscillatory flow zones. These areas of the epicardial vessels are often the nidus of atherogenic plaques. Now, high shear zones often exist near the throat of obstructive lesions. These high shear zones can cause vulnerable plaque transformation. Based on both animal and human studies, we have defined low shear stress to be less than 1 Pascal. Oscillatory shear stress or very low shear stress is often defined at less than 0.5 Pascal, whereas the normal physiologic shear stress, which is vasculoprotective, is often between 1 to 2.5 Pascal. Indeed, in a cohort of patients treated at Emory for STEMI, Dr. McDaniel and colleagues noted that the culprit lesions are frequently located immediately distal to the bifurcation and in the proximity of major curvatures where disturbed flow is known to occur. This supports the theory that wall shear stress is related to ACS. And so we believe that early atherogenesis might be initiated by very low and oscillatory shear stress. Early plaque formation is followed by expansive remodeling. And early plaque formation is followed by expansive remodeling of the vessel wall in an effort to maintain the vessel diameter. Low shear stress by causing inflammation and activation of local receptors causes lipid accumulation and formation of non-stenotic thin cap fibroatheroma. As there is plaque progression, high shear stress becomes a major player. High shear stress, by activating local MECHANO-TRANSDUCTION, increases inflammation, causes large necrotic core, and transforms the plaque into stenotic thin cap fibroatheroma, which ultimately can rupture and cause ACS. So what is wall shear stress? Wall shear stress is the tangential stress resulting from the friction between blood flow and the endothelial surface of the vessel wall. This red arrow is the normal force component associated with blood pressure, and the green arrow is the tangential component force associated with wall shear stress. When blood flows through an artery, it exerts force on the vessel wall. The perpendicular component of the force vector is associated with blood pressure, leading to deformation of the cells in the vessel wall. The tangential component of the force vector is actually much smaller and can be sensed by the endothelium through a shearing deformation. Now, if we normalize this tangential force vector by area, we obtain wall shear stress. Wall shear stress is actually quite smaller in magnitude than other mechanical stresses affecting the coronary arteries, but it exerts its powerful vascular effect not by mechanical impact on the vascular structure, but uniquely by triggering biological signaling. So wall shear stress is derived from the Navier-Stokes equation, which is essentially the Newton's second law, which defines force is equal to mass multiplied by acceleration. So to derive shear stress, we need measurements of blood flow, vessel geometry, and blood viscosity. Now, velocity profile can be calculated by placing a combo wire in the vessel. We can then use angiographic images to create a center line of the vessel. Then IVUS frames are stacked on the center line to create accurate boundary condition. We then use computational fluid dynamics to compute shear stress. Our group with David Maloney and Adrian Lifeux have created a quicker, novel method to calculate shear stress. We now rely only on angio images to create 3D models of the vessel, and then we calculate the time difference between the frame at which contrast enters the target vessel and the frame at which contrast reaches the distal landmark of the target vessel to derive the velocity profile. And as you can see, we can then use CFD to compute shear stress over a full cycle. While we can compute shear stress at any time point of the cardiac cycle, we have observed that the maximal clinical value is derived by averaging the wall shear stress across a full cardiac cycle. Using these novel computational techniques, we found that as much as 71% of coronary segments with low shear stress demonstrated severe endothelial function in patients with non-obstructive coronary artery disease. As you can see, fascinatingly, absolutely no coronary segment with low shear stress had normal endothelial dysfunction. In this nonlinear graph, we can see that the probability of endothelial dysfunction increases to 95% in the coronary segments that demonstrate low shear stress. Coronary segments with low shear stress often co-localize with segments demonstrating endothelial dysfunction. Hence, our group, along with the groups at Brigham and Women and Mayo Clinic, have proposed that the pathway to atherosclerosis progression might be mediated by low shear stress, especially in patients with non-obstructive CAD. So low shear stress induces endothelial cells to become apoptotic and dysfunctional. It causes infiltration of LDL and lipid oxidation, local inflammation, enhanced platelet activation. It attracts monocytes that differentiate into macrophages. Hence, low shear stress leads to progression of atherosclerosis. Now, Dr. Samedi in his seminal paper showed that coronary segments with low shear stress demonstrate greater progression of plaque area and necrotic core during a follow-up period of 6 months when compared with segments demonstrating intermediate shear stress. Our collaborators from the Brigham and Women, Dr. Stone and colleagues, conducted a sub-analysis of the PROSPECT trial. Now remember, this study recruited patients with ACS and followed them for 3.5 years. Non-culprit lesions with low shear stress at baseline were found to be at a greater risk of cardiac events. The highest risk of future MACE was attributed to those lesions who at baseline demonstrated both high-risk anatomy as defined by IVUS and low shear stress. In the prediction study, more than 500 patients underwent 3-vessel IVUS at baseline and 6 to 10-month follow-up. This was a prospective study, again by Dr. Stone's group, where patients presenting with ACS were interrogated at baseline and again at 6 to 10 months using IVUS. Non-culprit lesions with low shear stress demonstrated a greater change in the lumen area, resulting in a lower lumen area at follow-up. Low shear stress segments demonstrated a greater change in plaque burden at follow-up as well, indicating a greater plaque progression at follow-up. Hence, in the prediction study, low shear stress and large plaque burden at baseline were associated with worsening of clinically relevant luminal obstruction requiring PCI. And indeed, the positive predictive value generated from combining these two variables, that is plaque burden and low shear stress, was 41%. So low shear stress is associated with endothelial dysfunction. Low shear stress is associated with plaque progression, and low shear stress is associated with greater risk of future non-culprit MACE. High shear stress. So what about high shear stress? High shear stress stimulates endothelial cells to produce plasmin and transforming growth factors. It stimulates macrophages to release metalloproteinases, which degrade the collagen and matrix. And it stimulates macrophages to induce apoptosis of smooth muscle cells. Hence, high shear stress increases the necrotic mass, decreases the number of smooth cells, and ends up decreasing the fibrous cap stability. Within atherosclerotic plaques, high shear stress is associated with progression of necrotic plaque and greater development of expansive remodeling. Within a lesion, high shear stress zones tend to demonstrate thinner cap and more plaque ruptures. In cardiac CTA-based studies, culprit lesions have been shown to have higher shear stress. High shear stress is also associated with CT-derived adverse plaque characteristics like low attenuation plaque and napkin ring sign. So we took the FAME2 study patients and found that patients with high shear stress at baseline had a greater risk of future MI during a 3-year follow-up period. In this study, we used our novel methodology to use angiograms for both 3D reconstruction of the vessel lumen and for computing shear stress using computational fluid dynamics. So now remember that patients recruited in the FAME2 trial were patients with stable CAD who were randomized based on an FFR strategy to PCI and a medical therapy group. Interestingly, FFR only showed a trend towards predicting vessel-related MI, but it was not significant. We also found that wall shear stress calculated in the proximal segments of the lesion had the greatest predictive value. Proximal wall shear stress demonstrated a significant incremental prognostic value over FFR to predict future vessel-related MI. Here is an example. And if you can see, the patient A has high proximal wall shear stress, and this patient suffered from vessel-related MI during follow-up. Patient B with lower shear stress did not have an MI during the follow-up period. Interestingly, both these patients had a positive FFR of 0.71 at baseline. Since we published this study, other groups have also used angiograms to calculate shear stress. In a recently published study, the authors combined data from two ACS trials, Prospect and IBIS. They found that high shear stress derived from angiograms when added to high-risk plaque features on IVUS had the best prognostic value to predict non-culprit lesion-associated MACE. Another recent study hints that even in lesions that have borderline FFR, angiographically derived high shear stress might be able to identify lesions at greater risk of future MACE. In this study, lesions with area stenosis more than 60% and shear stress more than 7.5 Pascal were at a greater risk of future lesion-specific adverse cardiac events. So high shear stress decreases fibrous cap stability. It is associated with vulnerable plaque transformation. Thin cap fibroathromas and areas of plaque rupture co-localize within regions of high shear stress. Culprit lesions demonstrate higher shear stress compared to non-culprit lesions. And high shear stress may help predict future myocardial infarction. Now, there are other hemodynamic forces acting on the plaque. And so another important local hemodynamic force acting on the plaque is axial plaque stress. Axial plaque stress is the axial component of traction acting on the plaque. Now, here is an example of a CTA from a patient who underwent coronary CTA as a part of routine healthcare checkup. This CTA demonstrated that upstream APS was significantly higher than downstream APS. About a year later, this patient developed acute MI, and the intravascular ultrasound here can show you that there was a plaque rupture at the same location where they found higher axial plaque stress at baseline. So we looked at the FAME2 data set as well and found that higher axial plaque stress only in the proximal segments of the lesion predicted future vessel-related myocardial infarction. In this patient, the FFR was 0.52, the shear stress was high at above 10 Pascal, and the axial plaque stress was high, above 1400 Pascal. This patient had a vessel-related myocardial infarction during follow-up period. Now, high plaque structural stress can also be a principal mechanism for plaque rupture, resulting in thrombosis and sudden ischemic clinical events. In addition, localized high plaque structural stress concentration can also affect the cellular function, modifying the structural integrity of the plaque. PSS is calculated through finite element analysis and represents multiple variables in the plaque geometry and tissue material property and hemodynamic forces acting on the plaque. In the Prospect trial, they found that high PSS and high heterogeneity in PSS is associated with increased risk of future MACE in lesions who had VH-IVUS defined thin cap fibroathroma. So hence, ladies and gentlemen, I think we can propose that coupling advanced imaging with computational vascular diagnostics can help us predict future ACS. Now, how to make the process of computing shear stress quicker? Well, David Maloney from our lab devised a way using deep learning to automatically segment the IVUS frames. As you can see, he found a very high degree of correlation between the actual lumen area and the computed lumen area obtained using deep learning algorithm. We can use these deep learning algorithms for plaque phenotyping too with a very high degree of assurance. We are working with our collaborators at the Case Western University to develop deep learning algorithms to segment and phenotype OCT images as well. Using these deep learning technologies, we are able to precisely map the location of coronary segments with high shear stress and thin cap fibroatheroma. We recently found that OCT frames with high shear stress were twice more likely to demonstrate thin cap fibroatheroma compared with frames which demonstrated low shear stress. Now, for a truly useful clinical tool, we need shear stress to be derived quickly, but ideally non-invasively as well. And hence, our lab has been working with Dr. Peter Stone and Dr. James Min to improve the accuracy of CT-derived shear stress. Now, obvious challenges are accurate flow derivations, lower resolution with CT, and blooming artifacts generated from calcium. We found that there is an acceptable agreement between shear stress derived from cardiac CTA and IVUS. And hence we think that local shear stress mapping using non-invasive CCTA is feasible despite its lower resolution. And hopefully the prognostication will improve as the CCTA technologies improve. In the Emerald study, 72 patients with available CCTA underwent computational vascular diagnostics. Atherosclerotic lesions were characterized by using conventional anatomical parameters such as diameter stenosis and lesion length, and then high-risk plaque features like positive remodeling, low attenuation plaque, napkin ring sign, and spotty calcium. And then they also used they also conducted hemodynamic characterization of lesions using the very popular FFR CT, delta FFR, which is really the FFR gradient across the lesion, shear stress, and axial plaque stress. And as you can see, that CT-derived delta FFR, diameter stenosis, and shear stress were the three strongest predictor of ACS in this study. And indeed, in the model in which they combined anatomy, which was diameter stenosis, adverse plaque characteristics like your positive remodeling and things like that, and adverse hemodynamic characteristics like shear stress and axial plaque stress, this combined model had the highest predictive value to predict future ACS. And you can see in this LAD lesion, which had both adverse plaque characteristics and adverse hemodynamic characteristics, this patient developed ACS during follow-up. While this other lesion, which had adverse plaque characteristics, but not adverse hemodynamic characteristics, did not develop ACS during follow-up period. So the concept of radiomics is coming to us, and radiomics is leveraging non-imaging modalities to create a large data set, which we then analyze using plaque-specific anatomical, biomechanical, and biochemical matrices to create a model which can predict future ACS. Now, shear stress mapping can help improve stent profiles as well. We have come a long way from starting from bare metal stents. However, the bioresorbable scaffolds, where the scaffolds get absorbed into the coronary vasculature, thus restoring the original vascular geometry, we thought that this was the pinnacle of stent technology. And hence, it was very surprising when the Absorb BVS, which is the bioresorbable or the BRS platform from Abbott, demonstrated higher rates of device thrombosis and target lesion failure compared to the market standard of Xience stents. Now, as you can see, when the struts are boxy and non-streamlined, they cause large areas of low and oscillatory shear stress, while streamlined struts have smaller zones of low shear stress. This phenomenon also depends on the strut size. So bigger struts will cause larger zones of low shear stress. And there is often a heterogeneity of shear stress zones around non-streamlined struts with high shear stress on top and low oscillatory shear stress below. This phenomenon causes local inflammation leading to platelet activation and inflammation, and probably leads to future thrombosis. A previous study also hinted that BVS segments demonstrating lower shear stress demonstrated greater neointimal thickness at follow-up period, during follow-up period. You can see here very clearly that compared to the smaller Zions, the absorbed BVS has greater strut height and a design which could perhaps generate larger areas of low shear stress and could possibly explain why we see a higher rate of device thrombosis with the absorb platform. And hence, using our previously described methodology, we conducted a biomechanical analysis of the ABSORB3 imaging data and showed that the BVS platform was associated with lower shear stress compared with Zions. Here is a case example of the BVS device demonstrating low shear stress across the stented area. In comparison, the Zion stents demonstrate more physiological shear stress. Now, as many as 22% of BVS, of the BVS stent demonstrated low shear stress immediately after implantation, while only 6% of the Zions demonstrated low shear stress. So the low shear stress associated with BVS might explain the higher rates of stent thrombosis seen with the BVS platform. And so we found that low shear stress was associated with less residual plaque, less stent under expansion, higher eccentricity index. Interestingly, BVS stents were 5 times more likely to demonstrate low shear stress when compared with Zions. So our paper got some press and prompted a talk about whether BRS stents with thinner, more streamlined stent design should be given a chance to come back. And indeed, several new BRS technologies with more favorable hemodynamic profiles are currently being tested across the globe. Here you can see that some of the newer BRS platforms, such as the Phantom Encore with a strut height of 98 micron, are associated with smaller areas of low shear stress compared with the absorb BVS. Similarly, if we make the Magnaris edges more streamlined, this will also lead to smaller areas of low shear stress compared with the earlier Magnaris design of boxy rectangular edges. We are also currently enrolling patients to compare the conformability and shear stress between two stents, Resolute and Zions, in an effort to see which one of them has a more favorable impact on coronary vascular hemodynamics and stent implantation. One of our co-fellows, Sonali Kumar, is leading a study linking under expansion to high shear stress. Now we can utilize micro CFD to map shear stress and accurately localize high shear stress zones across a malapose strut. Here's a fly through, and as you can see, there you can see that you can accurately identify the red high shear stress zones on top of the malapose struts. Now, one of our collaborators, Dr. Hazizis from the University of Nebraska, is leading efforts to pre-plan complex coronary procedures using computational techniques. His patients often undergo pre-procedural assessment using IVUS OCT or cardiac CTA using computational simulations. He then figures out which complex PCI technique might suit a particular lesion the best in an effort to optimize patient outcomes. He is also testing novel dedicated bifurcation and left main specific newer stent technologies using computational imaging modalities. We now think that it is safe to do PCI with TAVR, yet there is a need to use more plaque-specific indices such as shear stress for more accurate functional assessment of CAD in patients undergoing TAVR. Computational diagnostic modalities could also be used to test newer valve technologies and their association with the creation of transcatheter valve-associated neosinuses, which are often associated with risk of valve thrombus. Computational diagnostic modalities can also be used to test novel TAVR implantation techniques to figure out if they are associated with improved clinical outcomes. Computational imaging is being used to test out the impact of mitral clips on leaflet stress. Computational imaging can help us pre-plan optimal mitral valve implantation strategies. Computational diagnostic methodologies were used to test our newer VAR technologies. So in conclusion, low coronary shear stress is associated with endothelial dysfunction and plaque progression. High coronary shear stress is associated with vulnerable plaque transformation. Computational imaging can help plan coronary interventions. So I would like to take a brief moment to thank all the engineers working at the Emory Core Lab who have worked with us over the years. Of course, I need to acknowledge Dr. Samedi, under whose mentorship I have done all my research at Emory. There are multiple fellows in the past who worked on this subject, multiple scholars who came from Korea and other countries who helped us. I also want to acknowledge people like Dr. Devi Reddy, Dr. Thames, Dr. Clements, under whose clinical mentorship I worked here at Emory. I need to acknowledge Dr. Neil Dickert. I think without him, I wouldn't have been here. And Dr. Robbie Williams, of course, for helping me throughout my fellowship. And I'm open for questions.
Thank you, Arnav. Very good review. I guess I have maybe less of a question, just more of a comment, just sort of, it's just interesting to hear as you sort of a budding interventionalist, sort of your approach to this topic, whereas maybe I see the Courage trial as and other similar trials, Ischemia trial and what have you, as maybe confirmation of the efficacy and improvement in medical therapy over time, and less as a condemnation of, interventional cardiology techniques and that sort of thing. I mean, I guess I can see as an interventionalist, you would take it as, all right, well, how can we make what we're doing better, more effective, more efficient, et cetera? Actually, when I read those trials and I see those trials, I see it as, wow, medical therapies come a long way. But I'd just be interested in your thoughts on sort of those differing philosophies or reads on those trials.
That's a great point. Thank you for sharing.
Other questions from the audience?
Robbie, it's Peter Block. Can I ask a question?
As many as you want, sir.
Arnav, nice review. I enjoyed that. This sort of impacts a little bit Robbie's question as well. So if shear stress is bad for you, it looks like any kind of shear stress, low or high, is bad for you, but you can't get rid of shear stress because shear stress develops when a liquid goes by a solid structure. But how can we, if low shear stress is the beginning of atherosclerotic plaque, how can we prophylactically change that in a positive way or in a negative way, depending on how you want to look at it, to minimize the risk of atherosclerotic progression going forward? Do beta blockers do this? Do ACE inhibitors do this? Or do ACE inhibitors actually increase shear stress? How does that all work out?
Mm-hmm. Yeah, it's a very good point, because in one of my slides, I showed that, all of us have coronary bifurcations. And obviously, these zones are the places where atherosclerosis develops. And there has been small trials, one done by our group with Dr. Samedi and I think Dr. Michelle Corban and Olivia Hung, that they recruited about 30 to 40 patients and looked at the impact of atorvastatin on low shear stress zones. That trial, we had a decrease in shear stress values over follow-up, but it was not very significant. We think that it's probably because we didn't have enough number of patients. So one of the ways we can do this is probably enroll a large number of patients and sort of do something what they have done with CT calcium scores in large population-based studies. But obviously such trial will take a lot of investment, and it will definitely need a lot of work from the engineers and the trialist as well.
Arnav, Spencer here. That was terrific. You talk about in the beginning how ischemia is not the best predictor of clinical events, and that we need to be looking more toward mechanical forces and look at the anatomy and so forth. And you showed a study that correlated the shear forces with other solid variables in plaque, but the one you didn't mention yet was lipid content. And so it looks like an opportunity to combine what we've learned recently about lipid content. And to answer Peter's question, from the interventional perspective, of course, creating a new shear force could be created by putting a stent in there, or putting something in there that would alter it. Also, the plaque thickness, the cap thickness, of course, the concept of preventive stenting of lesions that are judged to be vulnerable. But also with Robbie's comment, if you know you've got these kind of features, both about both fluid dynamic and solid features, of course, then you maybe can predict more accurately future events, and then the powerful medical therapies that we've got could be targeted more to those people. I guess that's
so,
where you're headed with this whole research.
Dr. King, thank you for bringing it up. I should have probably put a slide on that too. What Dr. King was hinting at was that there is a recent study where shear stress zones have been co-localized with large lipid core index of plaques using NIRS-IVUS, which is near infrared spectroscopy. And so really the most fascinating thing for me that I have learned throughout this journey is that a single matrix is probably not enough to predict future cardiac events. And we really need radiomics, which is where you combine multiple parameters, biomechanical, anatomical, and fluid mechanics, to really find which patient will which are the patients we can help with intervention. And in fact, Dr. Hazizis is also working on nanotechnology and seeing whether these areas of shear stress we can develop, deliver precise medicines to these zones in animal models and see if that impacts the future shear stress.
Arnav Stan Sherman. Just sort of wondering where ischemia in terms of our usual ischemic parameters or tests fall into combining with our shear stress and our anatomy, and where's cardiac cath going these days? Is it going to take a day and a half to do a cath, or and are you going to be allowed to plan? First, you have to have a cath to plan, and then the next day you actually do stents. I mean, where are we headed with all this?
Right, and that's a great question. And one of the things that we are really excited about is the scope of cardiac CTA, because it can combine. It can also give you CT-FFR, and I think I showed you the Emerald study, and the Emerald 2 is right now enrolling. And so CT-FFR is the most clinically popular tool that we have right now, which uses computational imaging. And so we think that where we are headed is that we'll probably have a patient maybe far away from our cath lab. No matter where they are, they can get, if they have a good CT scanner, they send it to us, and we combine and do our radiomics analysis. And even if it's a left main stenosis or bifurcation stenosis, we can even put, we can actually plan out the kind of stent they need, and we can see how that stent impacts the shear stress numbers post-stent. We can simulate that. And maybe this whole journey takes a few hours, and then we can call that patient to our cath lab and go ahead with the intervention. I think that's the ultimate dream. I think Dr. Spencer King also had some thoughts about this.
Well, I don't see Arshad on this call, but he's given talks to us about the biochemical markers for predicting future events, and it seems like not only what you might see on CT, but maybe what you see in the blood of the patient might all come together to predict who it is. I mean, the final goal here is to figure out who's going to have that infarct and die. Yeah, right.
Well, thanks again, Arnav, for a very interesting topic and discussion. And thank you, everyone, for tuning in this morning.
The preceding program is copyrighted by Emory University.